Professor Carling and his group, in a 2013 article review on flu, says that aerosol transmission accounts for approximately half of all transmission events of flu. Can we propose and argue that 50% of all COVID cases are also by airborne transmission? Airborne transmission model, if established, will best explain the unprecedented rapidity of spread as described by CDC. It also can describe the common clusters of transmission, namely religious activities, hospitals, nursing homes, office, gyms, bars and restaurants, taxi. It also explains that the continued spread, despite measures against contact and droplet transmission, are already practiced widely. If true, this has important impact on preventive measures to be advised on top of existing measures, including use of N95 masks definitely for healthcare workers and improved tightness of whatever mask. My deduction is based after analyzing the following 7 topics. 1. On the size of COVID-19 floating in the air and its viability. I propose that in the air, COVID-19 should best describe as a particulate matter of PM 0.1. It should obey the physical properties of PM 2.5, which is what we talk about in air pollution. COVID-19 has a diameter of 0.1 micron. For PM 2.5 is 25 times bigger. So, if PM 2.5 can float, PM 0.1 can float even better. This is PM 2.5 and smaller particulate matters included. This is the virus in proportion. This can float in the air. This can float better. This is the flu virus of a similar size. It can also float in the air. When COVID floats, it can be floating singly or attached to other PM 2.5 attached. It floats for a few hours before settling down. It can be blown by wind, dispersed, and can travel from one room to another. Moreover, it is important, as described by WHO, that when it floats, it remains viable in the air. That means it can still infect you. Until COVID-19 is eventually inhaled and goes deeply into the lungs, it then displays its biological properties of multiplying. Second, on minimum infective dose. How many viruses does it take for you to inhale before you get infected? Below which you do not get infected. For example, for flu virus, 2,000. For SARS virus, 1,000. For COVID-19, according to Professor Shank, University of Birmingham, UK, he said 500 to 1,000. Now, 500 is a very low infective dose, and that probably makes COVID-19 more transmissible than SARS and flu. What does that mean? We can say that it is easy to get an infective dose of only 500 viruses. One single careless incident may be enough to get you infected. Thirdly, however, if you try your best to reduce the number of virus particles you inhale, like 100 or 200 each time, you can get multiple hits without being infected. Third, initial infected dose. If you get a heavy initial infected dose for flu, for SARS, for MERS, you will get a more serious illness. That is established. For flu, if you get like 2,000 particles, you get a mild illness. However, if you get like 200,000 particles, then you get a more serious illness, and then you get to go into the hospital for ICU care. Parallel to this argument, if you have a sudden influx of many patients to a country, like in Italy, Lombardy, then you can overwhelm the whole healthcare system and the death toll will increase. Fourth analysis. How is flu viruses emitted from a patient into the air, and in what amount and form? Now I borrow lessons learned from flu to project onto COVID virus. I'm quoting from a 2014 Advances in Virology review article on flu. Dr. Fabian and others made the amazing discovery that flu patients in normal tidal breathing is breathing out great amounts of viruses, about 5,000 per breath. This amount is enough to infect 2 patients by 1 breath. If we breathe into the air for 1 hour, the amount could be enough to infect hundreds of patients. The viruses breathed into the air is in what form? They are PM2.5 small particles that can flow for many hours into the air. The amount is huge. This is in contrast to what we mentioned about droplet infection, in which if you cough out or sneeze out, mostly they are in big droplets, like this, that cannot float. It can drop onto the floor very quickly within 6 feet. That's why for droplet infections, we have a distancing of 6 feet to be safe. Here, I would like to mention a real-life example in 1979, in which a plane in Alaska has to turn back because of engine trouble. The engine is shut, and the passengers have to remain on the plane for 3 hours. There was 1 infected patient with flu. Eventually, after 3 hours, he could infect 72% of all the passengers. So, this is a perfect example of one-to-many spread of the flu virus, probably by airborne transmission. Flu virus and COVID-19 are in similar size. How can the knowledge of flu virus be translated for us to understand the behavior of COVID-19? We know that COVID-19 has a lot of asymptomatic carriers or spreaders. They are positive by PCR. They have no signs and symptoms of cough, sneezing, or fever. Yet they are infective. Recently, Iceland did a whole population survey whether they are positive for this virus. Of those who are positive, they found an alarming 50% of them have no symptoms, yet they are infective. In the United States, in New York recently, the figure is about 30% plus or minus. One would then ask, if they are asymptomatic in terms of coughing and sneezing, how can they spread to the other person and be infective? He must be breathing the virus into the air to infect the other person, logically. Moreover, 2 days before signs and symptoms appear, this is the time where the patient has the high viral load, in which case he is only breathing, you cannot recognize him, but he is breathing a lot of the viruses into the air. So maybe that's where the high spreaders, super spreaders come from. We can say that as a preliminary conclusion from the above, we can explain the rapidity of spread of COVID-19 by the following combination of factors: asymptomatic, infective, breathing into the air, large amounts, hanging in the air as PM 2.5, not settling down, remain viable for 3 to 8 hours, small, goes into your airways, plus, most importantly, a very low minimum infective dose. I now quote 2 examples to support what I'm proposing. In March in Washington, there's a church choir practice involving 60 people. At that time, they are well aware of COVID-19 spreading around, so they are extra careful in sanitizing the hands on entry. No hugging, no shaking hands, and distancing. Most importantly, there is no one appearing sick, no one coughing, no one sneezing. They stayed for about 2.5 hours, yet 45 out of 60 of the choir members eventually got infected with COVID-19. The best explanation will then be an airborne transmission, which is the most likely. This represents a case of, despite effective and careful measures against contact and droplet spread, airborne transmission remains effective and efficient to transmit the disease from one person to many. My second example is about patient number 31 in Korea. She had eventually infected 5,000 patients. The detail is that she went to the church 1 day before she had the fever. Patient 31, this group in Korea. So she may represent a super spreader within the 2 days before signs and symptoms appear. The sixth analysis concerns number of patients, the duration of their stay in the space, ventilation, and concentration of viruses. It is only logical that more infective emitters, the longer they stay in a smaller space with poor ventilation, means higher concentration of COVID-19. Here, I'd like to clarify the difference between ventilation and turbulence. Opening the windows will let air in to flush out the virus into the open air, whereas turbulence, by opening a fan or turning the aircon on, will continue to disturb the PM 2.5 and the viruses that they cannot settle down on the floor and become quiet. So, ventilation is good, turbulence is bad. Assuming all the above are valid proposals, for self-defense, there are certain situations we should try to avoid. Casualties and hospitals are unsafe because there's a high concentration of viruses. Maybe that's the reason why 20% of Italian health care workers are infected. Jogging in the open air or the beach is safe. Taxis are unsafe because it's a small space. When you travel in a bus or tram, open all the windows. When it's cold in New York, when you close all the windows, it is unsafe. Similarly, closed environments like karaoke, the inside of restaurants are unsafe. When you dine, probably it's better to dine in the open air than on the outside of the restaurants. Lifts are probably safe because you only stay there for a short period of time. When you travel in India, it is probably safe if you travel by standing on the top of the train because the wind is blowing hard and you do not get airborne transmission. If you have to queue, you queue outside the building. Do not queue inside the building or the shop. It is also logical to assume that the longer you stay in an enclosed environment, you will breathe in more viruses. If it gets over 500, you will get infected. As a self-defense, if you want to buy takeaway, you go in, make an order, you go out to wait. When your number is called, you go in, you take it. Don't dine it in the enclosed space. You take it out, go home to eat it. Your exposure maybe is just 5 minutes. In that case, you don't get over the 500 virus particle minimum infective loads and you will be safe. In the future, I suspect that it will be safest to have wedding banquets, dining, and classes on the grassland in the open air. If you must go out to work, the mask is the only barrier between the airborne COVID-19 and my nose. Then the consideration number one is it has to be airtight to force the air to go to filter. Then it comes to the filtering effect. For the N95, it is designed to filter out PM 0.3 particles with a 5% leak. What if the COVID-19 is 0.1 micron? It is smaller. So, it is not 100% effective, but it is the best so far we can do. What about the surgical masks available to the general public? And sometimes even it's the only weapon for the healthcare workers. This mask is not designed to be airtight, so the leakage is from 100% to 20%. Is there a way to make it more airtight and more comfortable? If not comfortable, you will expose the nose or keep touching it and spread the virus onto your face. I have two suggestions to make a slight modification to the existing surgical mask to make it more airtight and more comfortable. I hope it can help everybody. By making a better mask, we are trying to ask for a discount from the virus as to the initial infective dose, so that it is not above the minimum infective dose. Even if you get infected, it will be less serious. This is the pocket. And then, to put it on, make sure it is as airtight as possible, as the lower end is attached to the chin, so it's a little bit more airtight. On the sides, maybe a little bit more airtight as well. But most importantly, it is much more comfortable, more acceptable, to make you more compliant with it, because you have to wear it for a long period of time, many days, especially for children, they don't like it. Secondly, if you want to make it more airtight, I would suggest that you can use microfiber tapes to put on the side of the mask to make it more airtight in special circumstances, especially you might be exposed to heavy concentrations of viruses in the air for long periods of time to protect yourself. Lastly, there's this fit test. When you try to breathe, if the filter goes in and out, then the air is being forced to go through the filter to get less virus into your body. We are getting a discount and to protect you as much as possible. Anyway, it is a very basic equipment, and we are trying to make the best out of it to fight the World War III. 希望大家一齊同心協力，戰勝第三次世界大戰 COVID-19。